Hi, everyone, and welcome to Massive Bio's Multiple Myeloma webinar. My name is Fiona Evans. I am the Director of Patient Advocacy here at Massive Bio, and I am joined today by Dr. Jose Sandoval Sus. We're going to discuss multiple myeloma. Hello, Dr. Sandoval, how are you?
Hi, Fiona. How are you doing? Thank you very much for inviting me again to these forums. I really like chatting with you and, with all our potential patients out there and family members. And thank you to Massive Bio as well for the invitation.
Oh, thank you. We appreciate your time. Can you give us a little information about yourself and what you do?
Sure, absolutely. So my name again is Jose Sandoval Sus. I'm an associate member at Moffitt Cancer Center. Working in South Florida, and mostly I see patients with what we call malignant hematologic diseases, being for leukemias, lymphomas, multiple myelomas, and all the other type of plasma cell diseases. And I also do bone marrow transplants and CAR T cell therapy.
Great. Very busy.
Indeed, yeah.
Well, we will jump right in here. So we're talking today about multiple myeloma. Can you give us a brief overview about that and its significance as a health concern?
Correct. Yeah. So multiple myeloma, it is one of the diseases that I treat. It is malignant. It is a blood, quote unquote, blood cancer, right? A hematological malignancy, as we like to call it. It makes up. It's a fairly uncommon cancer in humans. It's around 1% of all cancers, but it makes up to 10% of all malignant hematological diseases. So everything that we see, around 10% of everything that we see in our specialized clinic. Now, it is a little bit more common in men than in women, all right? And it is a little bit more common in older age. Well, older age now because, now 60s is the new 20s. Yeah. But, the median age of diagnosis is 65 years old. And is very important for us to know as well that is twice as common in African American patients than in other populations, than in Caucasian patients. But we also see it a little bit more in Hispanics as well. But especially it's more important in African American folks, and it tends to be a bit more common in men than in women as well. So even though it's not a very common cancer amongst all the cancers that we have, it can carry a lot of morbidity and sometimes mortality, but especially a lot of morbidity due to its symptoms that we develop due to this multiple myeloma.
Okay, that's interesting. Are there any other risk factors associated with multiple myeloma?
Really, there are not. Most of the times, there are nothing that we can identify as a risk factor or triggers, if you may, to develop this plasma cell dyscrasia. I'm talking about plasma cell dyscrasia or plasma cell disease because these are the cells that give rise to multiple myeloma. We call it plasma cells that are in these sort of like factory of blood that we have in our bones that are called bone marrow. And these plasma cells are part of this immune system, right? And the function of these plasma cells are mainly to produce very important proteins from the immune system that are called immunoglobulins. And I'm sure we're going to touch base on that a little bit later. But really, there's not a lot of identifiable risk factors for this. In the past, exposures to large quantities of nuclear energy, like, for example, atomic bombs or nuclear plant disasters and so forth. Yes, they have been related to multiple myeloma and certain of these plasma cell diseases. And yes, having one or more family members, direct family members, with plasma cell diseases or multiple myeloma, what we're talking right now, it does increase a little bit your risk. And also having an entity it is not cancer, what I'm going to talk to you about, but it's sort of like a precancerous state that is called MGUS, or monoclonal gammopathy of uncertain significance. That's a lot of to unwrap. It's a big term that doesn't make a lot of sense, and we call it MGUS. Just suffice to say that this is sort of like a precursor condition of multiple myeloma. I would say almost or all patients who have multiple myeloma at some moment in time in the natural history of their disease had this MGUS. All right. So patients who have this MGUS, or this abnormal production of proteins, have a risk factor to develop multiple myeloma. But not all patients with this MGUS condition will develop multiple myeloma. And this is important because around 3% of the population, of our population above 50 years, can have this MGUS. It's not something that you feel. It is nothing that is related to any type of symptoms or signs or changes in your health. But sometimes it can be detected by your primary care physician or other doctors when you go for some other different things. For example, if you are referred by a little bit of anemia, let's say that your red blood cells are a little bit below the normal level, or your kidney function is not doing well, or it has changed. Sometimes the kidney doctor or sometimes another type of doctor will test for this type of abnormal proteins in your blood, and then you have this MGUS. So sometimes we get very concerned about that. And yes, it could be a risk factor to develop multiple myeloma, but not everybody. In fact, the minority of patients that have this MGUS will eventually develop multiple myeloma. But it is a risk factor to do that, to have multiple myeloma.
Yeah. Okay. That's interesting. For people that do have multiple myeloma, what are the symptoms that those patients experience?
So symptoms per se depends how advanced is disease and how far out we catch it in their presentation, right? So when we have we can have multiple myeloma, what we call symptomatic multiple myeloma or multiple myeloma per se, that is characterized by some myeloma-defining clinical events, right? Or myeloma-defining events. We know it with the acronym of CRAB, C-R-A-B, like CRAB. So the C goes for high calcium or elevated calcium, which sometimes it can, if it's very high, it can, manifest by different kind of what we call constitutional symptoms or neurological symptoms. For example, people can get very fatigued, very sleepy, very somnolent, right? You can have alteration, some urinary symptoms. If you have very high calcium in your blood, you can urinate a lot more than usual, and you can actually get dehydrated. And you can have, changes of your mental status, that it can be pretty severe sometimes if your calcium gets really high, right? Now, the R of CRAB, it is for renal failure, renal impairment, or kidney failure. So patients can present with renal failure. The kidneys not working appropriately. The other one, that is the A, is for anemia, and it presents with a hemoglobin, with low red blood cells, right? Or hemoglobin that is usually, the official criteria is usually less or equal than 10 grams per deciliter. And what are the symptoms related to that? Usually fatigue, unable to do your normal the activities of daily living, and sometimes headaches and some other, what we call constitutional symptoms. And last but not least, and this is one of the most important symptoms and signs of multiple myeloma, because it's a cause of great morbidity, of impaired health in our patients, are bone changes, either bone lesions or fractures that can be very painful, right? Especially like fractures in areas where we usually do not expect them to have, like fractures of your spine, fractures of the long bones like the femurs, the humerus, like your arms and your legs and so forth. And pathological fractures. What is a pathological fracture? It's a fracture that you have without, with a stimuli that shouldn't give you a fracture. Just for example, if you're going up the stairs and suddenly you have a leg fracture. That is not usual what we expect, right? So that's what we call a pathological fracture. Patients with multiple myeloma are also very susceptible to infections. Okay, so especially upper and lower respiratory infections tend to be quite common in patients with multiple myeloma. One last thing that I have to say to our patients: a symptom that sometimes is on your multiple broad differential diagnosis of things that multiple myeloma can present with is like persistent severe back pain, right? That has not, that, that we catch what it is per se. When it's persistent, especially in older individuals, we always need to keep that in the back of our head. It's not common, but it could be a presentation.
Does happen. And I guess these symptoms vary among individuals depending on where in their diagnosis they're diagnosed. They could have mild symptoms or very severe symptoms.
Correct, and that's a very important comment that you're making here, because before that, what we call full-blown multiple myeloma or the symptomatic multiple myeloma, there's sort of like an intermediate phase in a lot of patients that sometimes we're able to catch it, that is between that precancerous condition called MGUS that we already spoke about, and multiple myeloma per se, that we call it a smoldering multiple myeloma. Now, it is not multiple myeloma. It's considered a precancerous condition itself, and it is. But sometimes you can have changes that actually, in some studies, but it's not like in total agreement, like 100%. But in some studies have been associated to sort of like an accelerated development of full-blown or symptomatic multiple myeloma in the next 2 years. That is when you have an increased a percentage of these abnormal plasma cells in your bone marrow, that we will talk probably later about this in a minute, in terms of diagnosis. But when you have more than 60% of these abnormal plasma cells in your bone marrow, or if you have more than one lesion on the bones detected by high-quality images, meaning, for example, like MRIs or PET scans, or if you have very high, what we call serum light chains on your blood, then you could potentially be at very high risk for developing like complications for multiple myeloma in the next 2 years. So those patients will need a very close follow-up, because they could be at a higher risk. It's not yet. And if you have one of those, one or more of those factors that I told you that I just mentioned, actually nowadays, since 2014, those patients are already considered multiple myeloma. Even though sometimes it's controversial among some doctors, most of oncologists nowadays are, even if you don't have what we call the CRAP criteria, right? The CRAP, like symptoms for symptomatic multiple myeloma, patients are being treated, even though they have smoldering multiple myeloma, but they have one of those three things that I just told you about: increased bone marrow plasma cells over 60%, increase of your serum light proteins in a ratio that is more than 100. It's a little bit complicated, or increasing one or more bone lesions in high-quality images like multiple myeloma, CT scans, or PET scan. They are treated as multiple myeloma. That's currently what the guidelines said.
Okay. And how is multiple myeloma diagnosed?
Correct. So multiple myeloma is diagnosed, one, by the criteria, clinically by the criteria you already mentioned, what we call CRAP criteria. And usually, the cutoff for elevated calcium in the blood, it has a certain value. It's usually more than 11 grams per deciliter. Or the renal failure, where we measure the kidney function using a value that is called creatinine, that is in the blood, right? When you have an elevated creatinine above the level of normal, usually above 2 or more than that, that's also concerning for that. Or anemia, usually multiple myeloma is usually 10, or hemoglobin of 10 grams per deciliter, equal or less than 10 grams per deciliter. Or bone lesions can be either fractures or what we call osteolytic bone lesions. And this is important because the lesions in multiple myeloma, the lesions on the bones, are usually, it's not like other solid tumors, let's say like breast cancer, lung cancer, and prostate cancer, and so forth, that they usually tend to form new bone. We call those lesions osteoblastic lesions. These lesions are called osteolytic lesions, so they tend to erode if you make the bone, like punch out little holes or in the bone. So if you have any one of those criteria plus equal or more, more than 10% or abnormal plasma cells in the bone marrow, then you will have a diagnosis of multiple myeloma. However, you can also have some more like solid masses, let me put it that way, that we call plasmacytomas. So it's a group in a solid mass of these abnormal plasma cells, right? So if you have that, that is the diagnosis of multiple myeloma. However, once you do the diagnosis, you also have a side to order in knowing what the kidney function is on the patient, knowing how the minerals in the blood, meaning the electrolytes, are doing on the patient, how your complete blood counts are doing, and so forth. You also need to quantify. You usually order in your blood because that's what you're going to follow to see how the patient is responding to your treatment. You're going to order something that is called serum protein electrophoresis, and that is to detect the abnormal monoclonal protein on your blood. Monoclonal protein is a protein that is being produced by cancerous plasma cells, and you're going to have a protein there that could be, and those proteins are the ones that I mentioned before that are produced by these plasma cells that are called immunoglobulins, right? And these immunoglobulins can be of different types. There's one that is called, the most common one is IgG. The second most common one is going to call IgA. And there's some other ones that are a little less common, like IgD, IgM, and in 2% of patients, there are patients with multiple myeloma that are not going to produce any type of these proteins, which is called non-secretory multiple myeloma. It's really strange type of entity, but it is there. Now, with that serum electrophoresis at the time of diagnosis, you're going to also order something that is called serum immunofixation. That is to tell us exactly what type of protein is elevated, if it's IgG, IgA, IgD, IgM, etc. And also, you're going to always, we're going to order something that is called serum-free light chains. That, usually the plasma cells produce immunoglobulins that are composed of a big protein, let me put it that way, a big protein that is the one that we already talked about, the immunoglobulins, right? IgG, IgA, IgM, and a small protein that we call it light chains. And they're usually two types. One of them are called kappa light chains, or the other one are called lambda light chains. Some usually, for almost all multiple myelomas will have some type of these light chains that are elevated. And usually, not usually, but in a good proportion of these patients with multiple myeloma, we will only have production of light chains, not of the other immunoglobulins. So it's very important to measure all of them at baseline, because that's actually how we're going to quantify the improvement, or how we're going to measure the response to treatments in patients with multiple myeloma. We also are going to do, baseline images, specialized images for nowadays. In the past, we used to do what we call bone series. That is a little bit less specific and sensitive to detect lesions in multiple myeloma, especially if it's sensitive. We still do it in parts of the world where we don't have access to the other images, but nowadays, images that we prefer to use are either MRIs, magnetic resonance, or what we call low dose CT scans, or PET CT scans as well. So all of them are needed at the very beginning, and we usually do the same test that we do in the blood, in the peripheral blood for these abnormal proteins. We also do it in the urine, and we usually use a 24-hour collection of urine. The urine tests are very important at baseline, and especially in patients who have an abnormal kidney function. And but usually, when the patient gets into a complete remission, that's what our goal is, right? Put the patients in the deepest and best remission that we can. Usually there's a little bit of a debate now that we have these serum light chain measurements that are very sensitive and specific to follow the disease course in our patients. There's a little bit of a debate if keep on doing this serum. This urine test in the future is going to be very helpful because it's a little bit cumbersome, collecting urine for 24 hours and so forth and so on. And of course, at the time of diagnosis in the bone marrow, and I don't know if you're going to ask me this, but let us talk about this right away. When you do the bone marrow biopsy, on the bone marrow biopsy, we're going to order certain cytogenetic tests, meaning that we're going to look for specific mutations that have been very well described in multiple myeloma patients through the years that we know that have prognostic implications for our patients. And then based on this and some other clinical features, we're going to stratify the patients in either a standard risk, intermediate risk, or high risk based on some of these mutations and so forth.
Mm-hmm. Got it. Okay. And I was actually going to ask if there are any other procedures. So, there's your basic lab work, more complete involved lab work, CT scans, PET scans, MRIs, and a bone marrow biopsy. Would there be any other procedures involved for patients, or is that, kind of everything that they would need?
What I'm telling you right now is usually it's standard of care. Okay. But it is very important for us and for the patients and the family members to be their own advocates and make sure that they have like a complete workup. It is very, very important sometimes that we see from some referrals that they don't include some of the testing. Especially, I'm talking about baseline testing, the 24-hour urine protein assessment and light chains, especially the what we call the urine electrophoresis in 24 hours. That is very important. Sometimes they send like what we call a spot urine testing, and that's not as accurate as a 24-hour, what we call UPEP, urinary protein electrophoresis. The cytogenetics of the bone marrow are really, 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 really important for their initial risk stratification for prognosis, to determine a prognosis. Also, it's very important to determine, because that's part of how we do the staging of the patient. Mm-hmm. Two tests. That one is including the complete metabolic panel. That is the albumin level, the serum albumin. That is a very important protein, and also one that is called beta-2 microglobulin. So, and another one that is super important as well is determining something that is called the LDH on the serum, on the blood. Mm-hmm. So with beta-2 microglobulin levels, with the serum albumin levels, with the LDH levels, and with the cytogenetics on the bone marrow biopsy at baseline, we're able to do the staging of the patient and also to do an appropriate prognostication of what to expect from their disease.
Excellent. Okay, so that's great to know. Mm-hmm. So I know you're talking about different medicines and, over how many years we've seen them and what they're doing. Is there anything else you wanted to mention about how medications have evolved over the years?
Yeah, absolutely. Yeah. So, usually these and this is really, really amazing in this disease, So usually what we do is that we take medications that are in clinical trials, right? We take medications that are usually approved and they have activity in later lines of therapies, meaning when the disease have come back several times. Mm-hmm. And when we see that they have a good effect on the disease and they actually improve outcomes for patients, we try to bring it earlier on. Okay, so that's, for example, as an example, all of these medications can go through this pathway. But as a more recent example, a more contemporary example, is these agents that we call anti-CD38 antibodies, right? So initially we look this in folks who have relapsed refractory multiple myeloma, meaning the multiple myeloma has come back several times, right? And this, as a single agent, for example, daratumumab, as a single agent, had a response rate of patients that had some control of the disease, at least half of what they have at the beginning or more than that, had a response rate of around 35%. So that's after they have progressed up to 3 different lines of therapies. So that was impressive as a single agent, and we took that, then we put it on second line therapy, and the response was phenomenal, and nowadays I can tell you that for second line therapy, when patients progress, after the first line therapy that we already talked about, we should always, unless they are refractory to that daratumumab or that anti-CD38 antibody, every single patient should try to have one of these antibodies against CD38 as a second line therapy. However, remember what I told you, response rates of around 35%. Now recently, treatments that we have seen that really are right now being a revolution in multiple myeloma, and probably are going to transform the way we see multiple myeloma and the way we treat it, are two of them that I just speaking briefly about them before. First of all, these bispecific antibodies. Okay, again, there are antibodies against different proteins. One of them, the one that is approved, that is called teclistamab. It's an antibody that, let's say, that has two targets. One of the targets is on the multiple myeloma cell. I already talked about this. It's called BCMA. It's a protein outside the multiple myeloma cell. And there's another target that is called CD3, as in the T cell. So it brings the T cells and it brings the multiple myeloma cell and it puts them together. I like to joke, and I have talked about this before. It's like one of these online dating. You find the perfect match.
Sure.
The perfect match between that T cell and the multiple myeloma cell. So as a single agent, this molecule teclistamab has an overall response rate of 63% on patients who have progressed after 6 or more lines of therapy.
Wow!
So if you compare, right, before daratumumab had a response rate of around 35% after 3 or more lines of therapy, that was quite impressive. This one has more than 60% in patients that are way more heavily treated.
That's amazing.
Right? And there's another antibody that is not been, that one is approved by the FDA, but there's one that it has not been approved as of now, that is called talquetamab. It's a little bit of a tongue twister there. That has another different target on the multiple myeloma cell. That the response is up to 70% on this very heavily pretreated population. So these antibodies are being approved as single agents, but and there's already trials doing this. We expect for these antibodies to be brought to early lines of therapy, so patients, benefit from the potency and the strength of these antibodies. Of course, we have to do it in a very controlled way through clinical trials, and that's the importance of clinical trials and so forth. But it's very, very promising and very exciting for us doctors that treat patients with multiple myeloma. Now, the other agencies, the other line of therapy or therapeutic strategy for these patients are cellular therapies. There's a very classic one that we touch base a little bit on, that is autologous stem cell transplantation, that I think is very relevant, especially for younger patients with high-risk disease nowadays. But also chimeric antigen receptor therapy, or CAR T-cell therapy, with constructs or cells that are targeting these, again, proteins outside of the multiple myeloma cells. And again, I think we have talked about this in prior statements of Massive Bio, that CAR T cells are, we take T cells that are part of the immune system of the patients, and we transform them in, let's say, super soldier T cells. So these immune system cells can recognize in an appropriate fashion and in a very effective way these cancer cells, right? And they can destroy them in a very targeted and in very effective way. We do that by introducing a gene on these cells and make them multiply by million sometimes, and give them back to the patients. Now, there's multiple targets that being developed, but right now the 2 CAR T cells that are approved by the FDA target the same antigen or the same protein on the multiple myeloma cells. One of them is called ide-cel, or the long name, if you want to know, it's called idecaptigen vicluso, and the other one is called cilta-cel, or cilta-captigen autoluso, or cilta-cel. Their activity, the single agent activity, are the overall response anywhere between 80 to 90% in some series. and the progression-free survival is very impressive. Sometimes more than 1 year and a half and so forth, and sometimes more than 2 years in the patients that get really a really deep response with this treatment. And these patients are very heavily treated. The median lines of therapies are usually more than 5 or 6 lines of therapies, the ones who participate on these clinical trials. So again, I expect, and that's a trial that we just saw in ASCO, in one of our big conferences presented during the summer. It compared these CAR T cells against a standard of care, a treatment of care with an anti-CD38 monoclonal antibody that is one of our standards of care after 2 or more lines of therapy. So they brought it very early on, and they saw a phenomenal response, a very prolonged response. So it's not approved just yet for second line or third line therapy, but I foresee in the future with these very, very active therapies, both cellular therapies and bispecific antibodies, and combination of all of them will be taken earlier into the treatment of multiple myeloma patients to improve their outcomes. But again, all through very controlled clinical trials to make sure that it's a safe, there are safe process strategies to do, and to really quantify in a very systematic way their the outcomes of the patients.
Right. Yeah, that's very important. We'll jump right into clinical trials. That's my favorite topic. What, I know you've already touched on this, but what role do clinical trials play in the treatment of multiple myeloma, and who are the eligible candidates? Like how do they even become candidates for clinical trials?
So again, I touched base on this a little bit earlier, but during the past 15 years, the outcomes of patients with multiple myeloma has substantially improved, okay? And this have been not only by one-hit wonders, like boom, this actually changed totally the history of multiple myeloma. It has been by very, very well done and very well designed clinical trials through time. So it had been additive gains for the patients with multiple myeloma, right? Through time. And that had been through the participation in clinical trials, okay?
Right.
Now, what patients are candidates for clinical trials? I would say everybody. As long as there's a clinical trial available for the patients, anywhere from newly diagnosed multiple myeloma patients, all the way to what we call relapsed refractory multiple myeloma patients. If there's a clinical trial for the patients, that usually is my first choice of treatment, to offer the patients a clinical trial, okay? It's not always that, and unfortunately that's something that we have talked before, it's not always that we have availability in our community practices, access to these clinical trials. Sometimes yes, sometimes no. And I can tell you that unfortunately less than 10%, in fact, believe not, yes, less than 10% of all oncologic patients in the United States participate in clinical trials, and that's something that we strive to do, of course, to partners like Massive Bio and some other stakeholders, of course. But any patient should be try to be assessed for a clinical trial according to their availability, right? I think that's the only way really that we can advance the field, not only in multiple myeloma, but in other areas of oncology in general, right? And it's very interesting that there's also some clinical trials for earlier precursor conditions, so you can find clinical trials, let's say for smoldering multiple myeloma. Even they are starting to propose trials for MGUS, but I just a word of caution, right? These should be in very good control settings, and the oncologist should discuss with the family members and patients, the risk of benefits on participating in clinical earlier conditions, right? Because remember, these are patients that are asymptomatic, right? So they are at risk for developing something, right? But currently they are asymptomatic, right? So that's why we need to be careful in that's where the conversation with our patient and family members comes along. Very important clinical trials, especially for symptomatic multiple myeloma, newly diagnosed, relapsed refractory, and also eventually for these precursor conditions, but we need to be careful, okay?
So yes, that's very interesting, and I think one of the things that physicians do well, both in the practices and in clinical trials themselves, is they explain the risks, benefits of clinical trials. I think that patients are well informed, and knowing everything that's involved in the clinical trial is super important, and everyone should, like you said, advocate for themselves and find out as much as they can about clinical trials and what they entail.
Mm-hmm.
So one other thing that you briefly mentioned was personalized medicine. So how does personalized medicine play a role in the treatment of multiple myeloma?
So it depends on what we call personalized medicine, right? But in terms of personalized medicine, in the terms of let's say the most contemporary definitions of personalized medicine in cancer medicine, it's usually that we have a specific target on the cancer cell per se, and we find a specific drug that we can pair the patient, in a very appropriate way, not only that makes sense biologically, but clinically as well, right? Through clinical trials. Now, it is my understanding, and again, I'm not an expert in this part in multiple myeloma, that if you see an example in malignant hematology, like acute myeloid leukemia, right, that has been it's a little bit more ahead on this field of personalized medicine. Multiple myeloma, we're starting to see some things that are actually personalized, and we can pair the patient with the right medicine at the right time to get the optimal response that we need. I'm going to give you an example that is very, very straightforward in multiple myeloma. Around 20% or so of patients in multiple myeloma have cytogenetic alteration, meaning a mutation on their plasma cells or in their multiple myeloma cells. Mm-hmm. That is a translocation. That is what we call a translocation 1114. Okay. Now, in vitro, meaning outside of the patient, researchers noticed that these cells were very sensitive to a medication that we use in other conditions, like chronic lymphocytic leukemia, mantle cell lymphoma, or acute myeloid. Is called a BCL2 inhibitor, or venetoclax. Okay, and they took those findings from the lab, they translated, or they took it to the clinic, and they now know that patients with with multiple myeloma that have this translocation 1114 are very sensitive to this medication called venetoclax, and they actually achieve, and they're very prolonged responses when you do a combination of venetoclax with other anti-myeloma therapies. Right now, it is not yet approved by the FDA. Okay, if you see the NCCN guidelines, it is proposed there, but it's not approved by the FDA per se. And right now, they're running appropriate trials right now to see, how effective this intervention is in appropriate patient-specific mutation. But again, it is personalized medicine because of two things. One, we know that patients that have this translocation 1114 are very sensitive to venetoclax. However, in a big trial, a phase 3 trial, well, they treat everybody, right? Everybody with a venetoclax regimen, a regimen for multiple myeloma that contained venetoclax. Actually, there was a little bit of higher mortality in multiple myeloma patients, right? We really don't know. We think that there were a little bit more infections, but they really have not dissected the reasons of why the patients were, at a higher risk for passing away with that medication, right? However, if you go in that trial, if you go back and see only the population of patients who had the translocation 1114, they have a better outcome. So that's why that is personalized medicine, right? It's specifically choosing the right patient with the right mutation to treat with the right drug. But that's why, again, we shouldn't be doing this outside clinical trials. We shouldn't be doing this in a very controlled way, right? That is through clinical trials.
Excellent.
Now, and just to expand a little bit more on that, because that is a little bit more experimental, because the trials are they're just running right now, and they're very common. Multiple myeloma cells also have some molecular alterations that are recurrent, and they usually have, one patient with multiple myeloma can have up to 40 canonical, what we call somatic mutations, meaning acquired mutations, but common mutations in pathways that are involved in pathways that are mutated, that are commonly involved in multiple myeloma are, for example, pathways that are with mutations in NRAS, KRAS, and BRAF. We see mutated in other cancers, So there's also some medications that could be that could target those mutations specifically. And yes, There have been reports that there have some activity in multiple myeloma. But again, these need to be, through clinical trials, they need to be appropriately evaluated before we make any recommendations in that regard.
Yep, absolutely. So regarding treatments for patients, are there side effects? Sure, there are some side effects for multiple myeloma patients getting treated, and how do they manage those?
Again, I'm a true believer that, the part of the improvements in the outcomes of multiple myeloma patients is not only, of course, overall survival, how long the patients are, how good are they living, right?
Quality of life.
Living with quality of life, right? So yes, we have improvement in overall survival, yet yes, there are some related side treatments. For example, a common one that has evolved through time, and I think multiple myeloma, because patients need to be on therapies for their lives, at least in the standard of care setting, right? They will always be in some type of therapy, right? Physicians and associate healthcare workers taking care of these patients have developed a really advanced skills in supportive care, right? And I can tell you a couple of things. For example, bortezomib, carfilzomib, or these proteasome inhibitors have been related to, for example, peripheral neuropathy, right? And through time, and it was really debilitating at one moment in time, we started using that twice per week by intravenous route. Now, through time, we learned that using it in a subcutaneous fashion, sub-Q, and only once per week, it significantly decreases the rates of peripheral neuropathy. And again, bortezomib, that is sort of like the first generation of these medications, have more peripheral neuropathy, the higher peripheral neuropathy rates than the second generation, for example, carfilzomib or ixazomib. So, we have improved in that area. For example, lenalidomide or pomalidomide, these IMiDs, they have increased risk, for example, for infections. And they also have increased risk for, especially when you use it with steroids, at the same time, they also have increased risk for venous thromboembolisms, especially venous clots, sometimes arterial clots, but most of the time venous clots. And we have learned by giving some agents like, for example, aspirin, one baby aspirin especially one baby aspirin per day, or if you have clots in the past, some other anticoagulants, you significantly decrease the rate of these clotting complications. Infectious complications are very common in patients with multiple myeloma. Like I told you, these immunomodulators, inhibitors, and antibodies against CD38, they increase the risk, for example, of varicella zoster infections or shingles. So we learned early on that these patients needs to be on some type of prophylaxis to avoid these, herpes zoster reactivation or herpes zoster events that could be quite disabling and could, affect quality of life. Also, through clinical randomized prospective clinical trials, we know that when patients with multiple myeloma receive bone-modifying agents, in this case, for the most part, biphosphonates, like, for example, zoledronic acid, that is a very good example of that, actually, they decrease the chances of having major bone events, meaning, for example, vertebral or long bone fractures. At least on one trial, actually, it improved overall survival, the use of zoledronic acid, And there's some other agents, for example, like antibody against rank, like denosumab, that is used in breast cancer, which, in my opinion, I don't see much of a difference when you use biphosphonates. Usually, biphosphonates like zoledronic acid is my way to go. But if, for example, in patients who have really advanced, renal failure, sometimes those other agents like denosumab could be of help for us. But again, that's part of supportive care. Being on top of the vaccination of these patients are very important because, like as I told you, they have quite a bit of higher risk for infections, especially pneumonia. So it's a very important source of morbidity for these patients. And last but not least, these patients, just by the chronic use of steroids, can also have a little bit further bone damage. And there's a lot of other things that we can do. The patients can develop. These agents can have diarrhea. Sometimes we have some other strategies, supportive care strategies to decrease the incidence of diarrhea, skin rashes. These IMiDs, immunomodulators, they have a lot of skin changes sometimes. It's very important what I told you, and this is actually very, very important. We have known that not only through clinical trials, but through real world data afterwards, that the side effects are sometimes not the same, for example, in white patients than in Black or African American patients. For example, the skin changes are different with lenalidomide or pomalidomide in African American patients than in white patients. Things like that we're learning in supportive care. That the nurses and the nurse practitioners are really good at this as well. Okay, multiple the art of taking care of patients with multiple myeloma has a lot to do with supportive care as well.
Excellent. I know that everyone works so hard, and one thing that I, always point out to patients, anytime they have any kind of symptom, they should always discuss it. They should always, make sure that they're mentioning, all of the, even if they're minor things, just mention them so that, they can get that help they need. Next question regarding prevention. Is there anything that, patients can do in terms of prevention to, not get this disease? I'm sure there isn't, but is there are there any steps they can take to help along the way?
That's a good question, but unfortunately, there's not much information regarding that. Because really, there's no effective screening test for these patients. Although I gotta say, if a patient knows with MGUS, right, that we spoke about, or even in smoldering multiple myeloma, they should follow with their oncologist. Either every 6 to 12 months in the case of MGUS, or every 3 to 6 months in the case of smoldering multiple myeloma, depending on their risk factors. So the only thing I will mention about prevention is that if the patient is diagnosed with either MGUS or smoldering multiple myeloma, they should have a consultation with hematology oncology, and they should have a good established follow-up plan.
Yeah, very important. And I think even patients with no symptoms, just getting those annual checkups with your doctor, because basic blood work can give you some pointers as to if something, could happen, if something is amiss, but you're not having symptoms. Definitely keep on track with your preventative appointments every year, as we should.
It could very well be, but again, I need to emphasize there is no screening test right now for multiple myeloma. So we don't want to spook people.
Yeah, absolutely.
They have to start looking for this or anything like that. Yeah, thank God, it's a very strange disease. All right.
Yeah.
So, but anyway.
Good to know. Are there any common myths or misconceptions regarding multiple myeloma that you would like to put out there?
So multiple myeloma is not a cancer of the bones per se, right? It's a blood cancer from blood cells that we call plasma cells that are in the bone marrow, right? But they do affect the bones, but they also affect multiple other areas of the body, right? Multiple myeloma is not per se one-to-one hereditary condition, meaning that if I have multiple myeloma, necessarily somebody, my daughter or my son, there will have multiple myeloma. Is not one-to-one. In fact, yes, there's a little bit of higher risk for multiple myeloma to run in the family, but it's not. It's very strange to have like family clusters of multiple myeloma. Again, African American population has a little bit of higher prevalence of NGOS, myeloma, and multiple myeloma. All right, but this is very important. If African American patients with multiple myeloma have access that they need, either in clinical trials or standard of care outside clinical trials, they have the same or potentially even better outcomes that people who are not African American, they have multiple myeloma. This is important because if you see, and this is something, it's a pitch that I want to give patients in terms of clinical trials. All right. In the past, and this is important because we see a lot of disparities in multiple myeloma. All right. And then that's where one of my forte, and the one thing that I like to advocate for. Multiple myeloma is it's more common in African American patients, and you see multiple studies in African American patients. They come in later in advanced stages. They have worse prognosis. They have, they respond less to treatments and so forth. I don't believe that there's really, up until now, an objective biological measurement that makes those patients different from others. In fact, there's some studies that they have found out that African American patients actually have mutations in the multiple myeloma cells when they have multiple myeloma, in the multiple myeloma cells that are potentially related to better outcomes, like translocation 1114. However, I'm a firm believer that a lot of the of the not very good outcomes that were related to African American patients because lack of access to a proper, due to different type of issues, right? So one of the things that we need to talk to our patients, okay, being white, Black, Hispanic, Asian, whatever it is to try to get them to the right doctor, to get to the appropriate diagnostic workup, and to get to the right treatment, and to try to get them as much as we can, if available, to a clinical trial, okay? Because if you get the patient in the right setup of diagnostic workup with the right treatment at any stage of their disease, they will do as good as everybody else that are getting the appropriate treatment. Okay. Right. So that's one thing that I would like to say about that.
Yeah, absolutely. And we see a lot of patients that are in communities where they're underserved, and we do see them later on in their disease because they don't have access to care. So it's very important that everyone have access and, learn about clinical trials as soon as they can, when they're diagnosed. I know you're very passionate about that, and I love that. It's great. Anything else you would like to add about, multiple myeloma or clinical trials before we wrap up here?
No, I just think, again, as I told you, the services like Massive Bio and other platforms, they're actually expanding the access to clinical trials, right? Yep. And they try in a way, right? They try to decrease this, disparity of care that is in the access of clinical trials. One is that. And the other thing that I like to say, there are some, aside from, platforms like yours, there's some other very important resources for patients with multiple myelomas or related conditions, like, again, Leukemia Lymphoma Society.org, or even the International Myeloma Foundation is a very good source for our patients. Okay?
Yeah, there's lots of resources out there. And, one of the things we do, we try to, help patients at every stage. We never charge a fee. And if there is nothing that we can offer, we try to help patients find other resources that will help them. So we're always happy to help every patient that comes to us. And, you can reach us on the internet, on our website, massivebio.com, by phone, by email. We're always available and happy to help. So thank you so much, Dr. Sandoval. It was a pleasure speaking with you today. We appreciate your time. And that's about it for us.
Thank you very much, Fiona. Pleasure being with you. Massive Bio for the invitation.
Thank
you. Have a good day.
You too.
Okay.
Bye-bye.
Bye-bye.